appreciate your being here. I came to Baltimore in 2020. I've been Secretary of Health and Human Resources for 8 years. First under Governor McCall, then under Governor McCall, and then in 19 I was paroled in the custody of George Mason, where I worked for a couple of years, and then came over to the foundation right as COVID was beginning. I was at Mason. The president left and went to Georgia Tech. The provost had left, the vice president of research had left, the kids went home for spring break, and nobody came back except COVID. So I went to the Baltimore Charitable Foundation, and when I got there, they said, Bill, we've got this great program called Baltimore Scholars. I'm going to have Shirley Bestar tell you a little bit about that, because Shirley was the first grantee of the foundation for Baltimore Scholars back in 2006 when she was in kindergarten. You can laugh at that, it's okay. But at any rate, this thing really works. And we're helping kids. We want to help kids get into meaningful careers. And we chose healthcare because population's getting older, there's going to be need, and so many of these organizations in healthcare are really strong organizations, and they don't want you, so they'll help you with your education and your training. And we know that not every kid goes to college. And in fact, what I think we're talking about is proving to be extremely true. And I don't think we need to go into the workforce shortages, but what you may not know, you hear from the community college folks, that we've got 3.2 million Virginians today who do not have a certificate of any type beyond high school graduation. It is this need for workforce, and then the mismatch with how we're treating and educating and training our people is very real. So when I got there, we said there were 17 areas, and we come to it, and I said, well, let's look through and see what about this is working and what is not working. And at that time, Virginia, just prior to the year before, had set aside $30 million for the tech talent pipeline. Anybody heard of that? We're going to have all this tech workforce, but anybody here go into one end of the education system and came out the other end ready for work and is still doing that job? Just you, okay. You'll be back. Really happened. So we started looking into some of the challenges and the barriers. How do you get to kids earlier? Talk about that. The rigor of the education, particularly in STEM, was such that I would hear people from health professions say, boy, they check the box, but they don't know enough to be successful. The rigor. We know that the cost, many areas could not offer the training in high school. So if the community colleges came in through dual enrollment to offer it in many areas, that was a cost to the student. Students who most badly needed the help then would have another financial barrier to get it. And then how do we get teachers? I mean, if there's someone out there who can teach nursing right now, they're working for the hospital. If you go to a hospital administrator, this actually happened when the community college was talking about we're talking about expanding the program. She says, I hope they're not going to take my nurses to teach. And that is a big barrier. So all of these things came up. So we worked with the Hoyt over the course of the summer. At the end of this, we came up with a number of recommendations for the legislature and for localities and for employers. But the big idea here was that we needed to think about a lifetime for families and kids. Because it's one thing to start to a ninth grader and say, we're going to teach you to be an EMT, and that'll be your next step, and it'll be a great starting point. But we found out that if you didn't have the math in 7th and 8th grade, you couldn't take the science courses in 9th grade. So now we're talking to 5th graders. And when you go to the 5th grader, mom wants to know, well, it's nice you can teach a kid to be a tech or an EMT or something like that, but is that what they're going to do all their life? Or, so that's all you think my kid can be is a CNA, a certified nursing assistant. How do you get past that? So we needed to be able to show that this is a journey and that there is a pathway out there. That's one piece of it. The other piece of having a concept like this is that if you're in K-12, you say, I can do this part. Or if I'm an employer and I want to get involved in something, I can do this part. and the community colleges can play this role and so forth, but we're allowing for the fact that there are off-ramps and on-ramps, and we are trying to update the graphic to make it better and more explanatory, but life just doesn't go that smoothly. And when 62% of kids do not get a 4-year degree, we need to think of other ways to get them ready to go to work and to come into our and to come into healthcare. Again, meaningful careers that doing needed work, good work that allows people to grow over time. So with that, Shirley's going to say a little bit about Commonwealth scholars. Shirley, you guys start.
So in 2005, at a luncheon, our executive director, at that time the CEO of the Inova Hospital System in Northern Virginia and the school superintendent in Loudoun County, Virginia, where I was the director of career and technical adult alternative ed and family life. Yes. All came together at lunch and said, we really want to do something that is going to have an impact over the long term, and really looking at healthcare and workforce. Dr. Moore himself was a doctor, and actually one of the first chairs of radiology at the George Washington University in Northern Virginia. A self-educated man, did not come from any means or wealth, and really built a life and a career and a legacy for himself. So we wanted to continue that based upon all of those things that we knew were true to who Dr. Moore was. And so building that program, looking at workforce needs, obviously, why would you have a program if there's not a need for workforce? So about that time, building curriculum at the Department of Ed, bringing in higher education partners to offer opportunities for kids to get concurrent dual enrollment college credit, start building a college transcript. Additionally, down the line to pursue credentials in health workforce so that when you're coming out of high school, you're having a transcript, you've got stackable credentials, you literally are building a professional career for yourself in a particular highway on and off ramp. So we are in 52 public school systems. We started looking at, really the needs in each region, because every region of Virginia is very different. The needs are very different. So our program funds things from nurses to rad techs to pharm techs, surgical techs, EMTs, patient care techs. Some of those entry-level positions that kids could learn to earn while they continue down that highway model of further education. So we have really tried to look at reaching all regions of the Commonwealth of Virginia. But it's a program that receives philanthropy and supported by local operating monies, but really to start early exposure for kids to test drive careers, to learn that healthcare is not just doctors. And so that really is the mission of what we do with Commonwealth Scholars, is to give students an opportunity early to learn and to test drive some of these careers and to see if it's for them, because we all know that they are high-wage, high-demand occupations across the Commonwealth. And as you go region to region, and as you get into some regions of the Commonwealth, there's just not access to a healthcare system at all. So an EMT is the best person in your rural community to be there to help you. So Commonwealth Scholars is something we proudly brand, and it's our signature program at the foundation. Dr. Hayes, I'm going to turn that back over to you.
So in terms of the program, just to know, I'll Shirley will tell you this, but we have funded 4-H clubs. Believe it or not, many of you have extension agents in your area if you're rural. This summer there will be a van available that will provide some options for life sciences with curriculum that will go with it. Shirley has about 25 copies of the children's book that has been created on career opportunities in healthcare. You can see this beginning of a series. I understand there's one being written on dental now. Sarah will tell you about that possibly. But the idea is to get them engaged, get there early, and then see how they do. And again, if they find out it's not for them, an early win is a good win. And I think when you use the highway model, the other pieces, we can talk about people changing careers and reskilling and upskilling. Then the question becomes, if you buy into this, then it's how you do it. And which really becomes going from about thinking about it to doing it. And we have a grantee that's known as the Blue Ridge Partnership for Health Science Careers, which is in Roanoke. And this started sort of on a parallel track, probably in 2018 or 19, when Delegate Austin came back to get cancer treatment at MD Anderson, where the care team included kids from the high school system in Houston. They had a health science academy model there. And the care team himself, when he graduated from that program, and before I even come to Colorado, he saw me one day down there and he said, Bill, I need to talk to you. And I said, sure, Terry, what's up? And he said, I've got this idea, and we should have these all over Virginia, these health science academies. And 4 months later, I was at Colorado thinking, darn, let's put together. We had spent already, as a foundation, $750,000 going to the community college, which was just paying for dual enrollment costs. Not the optimal way to do something innovative. And so we came together, our leading Cynthia Lawrence worked with Carillion. Carillion has supported this and has developed a model of employer-led regional effort to grow the workforce. And when you listen to her, it's overwhelming, but over several years they've become pretty sophisticated, and they have a series of committees, all with charters and missions and a meeting cadence and goals and so forth. But long and short of it, it's what they did is they got the employers together and they said, what jobs do you need? And you can go to the various job posting, the roll-ups, what's the one?
Jobs EQ.
Yeah, there's Jobs EQ, but there are others that can tell you all the jobs that are out there currently, but they aren't really good at reflecting what skills are needed. And it is much easier for HR people to do a standard, right, you need this degree, than it is at 5:30 on Friday night to sit there and write out a very good job description. So they sat down and said, so what are the skills that are needed? So they've gone through that exercise and figure out what jobs today, tomorrow, and 5 years from now. And I've heard said by people from the education world that, well, we really don't need to talk to employers very much because we have accreditation standards we meet. If you say that to an employer, Roger, did you ever meet anybody that could rely strictly on their training with that? It just doesn't work. So they've worked into that. They've gone back into the K-12 system. This includes the Carillion, HCA, the Central Health System, 4 community colleges, 17 school districts, Bradford, Roanoke College, Virginia Tech, and Hollins, just to name a few, but really set up very well. People are represented throughout. They have a student ambassador program. They've gone through and they've looked at all the courses that are available in high school, not just theoretically, but are being taught, and have mapped out a career path or a course curriculum that, if taken, intentionally every course will transfer, every credit will transfer, and will set you up for a career. And no one had done that. So that will vary from region to region. But anyway, long and short of it, they've identified 10 job clusters, and they've mapped out some of these, how you get from where you are to where you want to be by region, where you go to get it, and how much it costs. So we think this needs to be done regionally. I can tell you we've also been involved a little bit with some innovation. Germanna Community College had a program with Mary Washington, an Earn While You Learn program. The students are working at Mary Washington, getting paid while they're getting their academic credentials. As we have shortages of teachers, we badly need that to happen. They came to us with the Rappahannock Area Community Service Board and said, we need workforce in the public sector for community services. So a curriculum was designed called Behavioral Technician 1. First cohort was graduated, second cohort is in. Senator Durant from Fredericksburg put in a bill in the General Assembly that would recognize this as a position that could be paid by the CSB as part of the care team. Doesn't solve the problem all by itself, but it's another creative step that has come together to try to make this work. The other thing that we've done is we have funded a workforce center at George Mason. It's the Center for Health Workforce, and we've committed multiple years to fund this. And 2 weeks ago, we just got $921,000 federal grant to support them. But they are able to regional data on sort of the jobs, the job projections and so forth, but they're basically also have a learning management system that our grantees get. They get 21 of the 23 career readiness skills that are required for career and technical ed in high school. It's available through the community college system. They do training and simulation. There's workforce data out there, and there's a really interesting system called, which is basically I call LinkedIn for folks who want to do health careers. It's a networking platform, and we've offered some scholarships to get people to sign up for the scholarships, and that way we can get better insight as to who they are and where they go and follow them more over time in terms of determining outcomes. So the point is there's an awful lot that's being done. And to make this go, we've had some contact with the administration, and I'm going to introduce Nicole Overley now, formerly from Deloitte, but who's also now the Deputy Secretary of Labor, to talk a little bit about work together that we're doing.
All right, thanks everyone. I'll just do a quick introduction of myself as well, and maybe just talk a little bit about workforce development more broadly, and I think really how it fits into this effort specific to the healthcare workforce, and really specific to this Blue Ridge model that Dr. Hazel talked about, because I think it's really remarkable, and I'm really excited to see the amount of activity across the Commonwealth in terms of partnership models like this. As Dr. Hazel mentioned, Nicole Overley, I'm Deputy Secretary of Labor for Workforce Development, and my role in the Commonwealth and in the Governor's Office is to focus on workforce development across every sector and industry across the Commonwealth every day. And the reason for that is because it demands, I think, an unprecedented level of focus than we've ever been able to really have before, and really, I think, represents a coalescing of focus around the Commonwealth on really what's needed for the future of the skills and jobs of the Commonwealth's people and our businesses and our employers. And so a couple of things I think to note related to that. Last year in the General Assembly session, legislation was passed to establish a new workforce development agency. If you don't already know that, I'm going to talk about it for a couple of reasons that I think it's relevant. It's called Virginia Works. Colloquially, it's the Department of Workforce Development and Advancement. And among other things, what it really was designed to do was to bring together a number of the programs, the disparate, significant number of programs. I think at last count we're at 72 state and federally funded workforce programs that operate across the Commonwealth for a variety of industries and a variety of purposes, but really to help coordinate and collaborate and connect the dots amongst them. So to operate almost a little bit as a hub and spoke model, and really I think to propel forward some of the more innovative ways of thinking that we're starting to see nationwide in the realm of workforce, one of which is sector strategies or sector partnerships. And I think the Blue Ridge model is a really exceptional example of that, and probably one of, if not the most complex industry that exists, which is healthcare. And I think it's really interesting just when you look, kind of across the U.S. from the vantage point of workforce development, we talk a lot about what a sector strategy is effectively to kind of bring together all these disparate players and how people think about skills and how skills are evolving and what employers are looking for, and how we collectively bring together educators, philanthropists, government, and business and industry to kind of solve those problems together. And so what I'm really excited to say, I think, is that the Blue Ridge model has attracted a lot of attention, not just in Virginia, but nationally, and I think across the Commonwealth, really organized by these regions that are up here, which are the Go Virginia regions. If you're not familiar with them, I can talk a little more about that. But there's really activity in almost every single region that the platform team has helped to kind of shepherd and identify around building similar types of partnerships. And I think it's really exciting to see it's something that the Commonwealth is really wanting to invest in, not just because of healthcare and the need for the healthcare workforce, but because this sector partnership model is one we can replicate for other industries too. And I think that would be a real game changer in a lot of ways for the way that we think about workforce development. So we're really excited about that. I think we can talk a little bit more about, if we want to, and maybe answer some questions later about the specifics of some of the things the Blue Ridge model is doing. Also, if you have questions about the regions with activity and how to get involved in that, we'd love to talk to you about that as well. But just suffice to say, workforce is an area I think that we will continue to have great focus on. It's one of the most complex questions out there, I think, of what workforce development really means and how we can work together on it. And we're fortunate to have the opportunity to come together in these types of collaborations and partnerships to really figure out how to make impact. Yeah, so the last thing that I think is probably worth noting, I mentioned that there's a lot of activity right now amongst a number of these regions. One of the things that together that we're spearheading over the course of the next really 12 weeks is an effort to really build a toolkit and some templates coming out of the Blue Ridge model to accelerate the activity that's happening in the other regions, and honestly also to build a toolkit that will be helpful for other sector and industry teams to think about doing this at broader scale. So, as if you haven't heard him speak about it, Secretary of Labor Brian Slater says a lot of our focus is on identifying what works and helping to scale it. And that's one of the things I think that we're really trying to do in terms of not only just building off of the success of the Blue Ridge model to date, but learning from it, but really thinking about kind of common outcomes in terms of placement, retention, recruitment of individuals in these roles. Trying to really make sure that we're focused on those outcomes, we understand them, but also recognize that different regions will do things differently, and there are aspects of local nuance that are really important to consider in models like this, and that's part of what makes it really helpful. So the Commonwealth's role can be to kind of help to surface some of the best practices, connect the dots amongst them, but really also recognize and make some of the nuance that is already happening with the way in which these are kind of coming up across Virginia.
So just a comment on this map. This is an important map for a couple reasons. The Commonwealth over the last couple of years has used this for economic development. Everybody here know what Go Virginia is. Growth and opportunity. These are the regions, and it is sort of now the language people are speaking. If anyone has heard Dr. Dore at the community colleges speak, who does a lot of the workforce training and everything, they're asking the schools to come together, the 23 to come together and think regionally and to prioritize what they want their investments to be in workforce going forward. All 9 regions have healthcare at the top of the list, 1 or 2. There are some have advanced manufacturing, some have IT careers, but healthcare is involved in every one of these things. When Nicole says healthcare is complicated, the challenge that makes us different and why we need this conversation is that think about the jobs. Is there a job in healthcare that isn't defined in some way by regulation or payment policy that is set either by the state or the feds? Is there anything that is done in healthcare that isn't paid for, either directly by government or by an insurance company, which for all intents and purposes is government surrogate with very similar roles? How often is the payment directly from government? How often is the person providing the service, think behavioral health, working for the government, one area or another? And then finally, who is responsible for most of the education and training? Public schools and public universities. And it is very difficult to break down the barriers as when to think about the rules and the regs that have come in that have, quote, protected professions over time. Don't always protect the patients or provide the services that are needed. So we have to think collectively about how we work in these areas. It has to be a group effort, and what we have been doing up till now has not been meeting the need. So I'd like to introduce Dr. Matt Luce from the Ballot Health System. Matt can tell you about their projects down there, but this is Greenwood one. In fact, they even go into Tennessee, unfortunately. But anyway, anybody got questions, I'll turn it over to you.
My name is Matt Harris. I'm a recovering general surgeon. I apologize in advance for that. And I'm currently serving as the Chief Academic Officer for Ballot Health. Ballot Health is a 21-hospital system that lives in Northeast Tennessee and far Southwest Virginia. And we basically encapsulate most of the GO region number 1. And you can see our statistics there. We serve a very rural population, which is not to say that it is unique within the Commonwealth, but it certainly is a very challenging area to work in healthcare. Access is a challenge as well. Our health system covers or encompasses a landmass similar to the size of New Hampshire. And when you're talking about trying to, whether it's go to the patient and deliver services or have those patients come to a hospital, clinic, etc., it's a real challenge. And so workforce is something that we are very invested in as an employer. And I think it's something also that causes us a great deal of heartburn, trying to make sure that we can maintain the workforce that we already have. So as you might be able to imagine here, as you look at these little dots up here, and hopefully you guys know the Commonwealth at least as well as I do, you can kind of pick out where these guys live. But we're dealing with a situation where not only is there a nationwide crisis in healthcare providers, so I'm sure you guys know that over the next 4 years, it's predicted that there will be 800,000 nurses that will leave the profession. I'm sure you guys know that in allied health, we're talking about tens of thousands of employment opportunities that will go unfilled because we don't have enough people. So for Ballot, we've really taken the stance that we need to work with our schools. And we've traditionally always worked with our higher education partners, and that's great, and we continue to do so. But going down into the high school and even into the middle school level, this is where we really feel our opportunities present themselves. And so we have an opportunity, we've had an opportunity to work with the Clarkmore Foundation in Wise County, Virginia, and we hope to continue to build upon that relationship and spread it. But in Northeast Tennessee, Ballot was successful in speaking with the Bloomberg Philanthropic Organization to partner to develop a pilot program where we are designing a school within a school model as opposed to a traditional charter school model. To try to develop kids so that they can be workforce ready at time of graduation from high school. And I know that's very similar to what the Blue Ridge Partnership is doing. The difference being is that we're investing a lot in some of the wraparound services that come with these kids. So a lot in our area, I think in the southern portion of the Commonwealth too, a lot of these kids have no experience with anything beyond primary secondary school. And so they don't understand what it takes to actually apply to college, what it means to get into college, what to expect when you're in college, these sorts of things. There are these endemic patterns, unfortunately, these cycles of poverty, of underemployment, of hopelessness that we're trying to break in our neck of the woods. And we believe that the best way to do that is through working with kids as young as possible. And so we can get into, I can happily get into the details of the academy. And what we're putting together right now in Northeast Tennessee, we want to move into Southwest Virginia. And before I go too much further, I'm only one head of the two-headed beast of this Ballot Academy. Dr. Jeffrey Morehouse, who is I guess I'll say recovering as well, superintendent from Sullivan County in Tennessee, is the director for the Ballot Academy, and someone who's really been taking this from concept to reality in lightning speed. So I'm speaking to you, but we both are singing from the same hymnal. So if there are questions or things that we can try to answer for you, we're happy to do that. The other thing too is once they get to us, once they graduate high school, hopefully with, you guys have heard CNA and LPN and those sorts of things, and we're doing the same thing because, as you know, the restrictions that are placed on a lot of health professions require those students to go on to post-secondary world in order to get those licensures or certificates. And so what we're trying to do is after we have those kids graduate, we guarantee them an interview at Ballot Health. And if they join us, we guarantee them continuing funds to continue their work in four-year college or other areas. In addition, we also provide them with counseling services, not only while they're in high school, but also post high school, so that they can continue to learn and continue to have the best opportunity possible to get into higher levels of education, go from LPN to RN to BSN, etc. And so we're really excited about the opportunity these kids that really have never had any attention really paid to them before are now going to be able to hold their heads high. So in the Commonwealth, our goal really is to spread the program into the Commonwealth, hopefully within the next year or two, depending on certain things lining up, as you can imagine. But we hope to be able to touch all of the areas that you see on this slide here within the next 5 to 10 years. That's, as you know, thousands and thousands of children that hopefully we can opportunities. So, let's see if my other slides. I put these slides together. So that's what we're doing. All right, kind of talk about stackable credentials. You probably all heard that as well. The importance of making sure that once kids are coming out with degree A, that they have a pathway to get to degree B and C and D. And so we're working with our local institutions of higher learning to make sure that we have that in place. At full function, this is what we envision to be the Ballot Health Academy. And you can see on here, not just nursing, not just CNAs, but every other aspect within healthcare that we can think of, and some that are not even on this picture. Kids today, what we found are they don't understand all the different roles that they can serve in healthcare. They think doctors, nurses, that sort of thing. Some of them don't want to deal with blood. Some of them don't want to deal with people. They want to work kind of behind the scenes. And so we believe that in our pilot program here, we're going to develop those pathways where kids from any walk of life, that's the other thing that's exciting about our program, is we're not tailoring this to the cream of the crop straight A students. This is open to everybody. That they can contribute, they can be part of giving back to their communities in a way that doesn't require them to have to be a doctor or feel the overwhelming pressure of trying to get into a college in order to serve. So we're very excited about this, as you can imagine. I apologize if I'm rambling, I'm just very excited. Yes, sir.
Can I add to that?
Of course.
That's fine.
So sorry, this is Dr. Jeffrey Morehouse. He is, like I say, director for the Ballot Health Academy, and thankfully will be here to make clear what I put.
What I would say is what Dr. Haley was saying was true in Virginia about the articulation of credit is also true in Tennessee. Is trying to make sure that courses that are taken will count towards degrees and stack on top of each other. So we're working on that. Looking at that full model is taking on this idea of a career by senior year, that we can get you into the work onto the healthcare highway, and all those areas, that there's multiple areas where we can back up the curriculum that's typically happened in a post-secondary, back that curriculum, redesign the courses in the high school settings. That's why I leverage my talents into helping redesign the high school. And we've talked about redesigning the senior year, redesigning high school for a long time, but this gives us the opportunity to truthfully do that. And so being able to get kids, once we can get them to employment, as Dr. Lowe said, being able to say, this is just the first step on the highway, this is the first on-ramp, and that we can continue to advance you down the line. We're not eliminating choices to them, we're just actually putting them on the path to multiple choices. But you've got to get in the car and actually be on the highway to be able to make any of those choices.
Thank you. Just not to be a little biased, the Bloomberg grant was $15.3 million. By getting started, this is what I think most of us in philanthropy want to do, is to help get the concepts developed, and then whether it's Bloomberg or RWJ or federal government money come in and make it last. And that's what we're trying to do. So this is just one example, and it's nice to see it work. And if anybody really wants to know what he just said, ask me. I can translate to Tennessee, okay? I'm going to do that. Sorry. Is that good? So the question comes up, you've heard about hospitals. We've talked about the focus so far, but there are non-hospital related things like oral health, often mental health, many careers out there, social work, and so forth that are critical if we're going to address what people are referring to as the social determinants. And so with that, Sarah Howland from Virginia Health Catalyst is here to join us.
Well, hi everyone. It's really nice to be with you this afternoon. My name is Sarah Holland. I'm the CEO of an organization called Virginia Health Catalyst. I'm going to take a couple seconds to just kind of describe Virginia Health Catalyst to you and talk about one of the initiatives that we have been working on to help further the oral health workforce and ultimately I think also fill in some of the gaps with some of the things that are happening, some of the really tremendous programs that are happening statewide and nationally. So first, Virginia Health Catalyst, we are a statewide public health nonprofit organization. We are about 14 years old, and our mission is to ensure that everyone in this very, very fine Commonwealth has equitable access to comprehensive health care, and that care includes oral health. As you can imagine, that is a massive mission, and we approach it both programmatically and through advocacy and policy change. A big part of our policy change work is at the state legislature advocating for equitable Medicaid policies. We wanted to make sure that somebody who's enrolled in Medicaid has access to all of the services that enable them to be healthy, including an adult dental benefit. We also work on issues related to efficiencies of practice, ensuring that in Virginia, folks are able to work at the top of their license and education and training. We also promote and advocate for policies that support access to services that help make connections with socially determined health needs and other environmental factors. A big part of what I think makes us unique, though, from an advocacy organization is we also work on the implementation and programmatic side. And we want to make sure that when a policy is enacted, it's followed through with really successful and comprehensive implementation. And an example of that is some work that we're doing with federally qualified health centers and diabetic and hypertensive patients. We are working with them on a quality improvement project so that the diabetic and hypertensive patients are getting all of the services that they need to make them healthy. That they're getting access to mental health services, they're getting access to oral health services, they're of course getting the primary care that they need, and they're getting any of the wraparound services that might help them be healthy as well. What does that have to do with implementation of policy, you might ask? Well, we passed an adult dental benefit in Medicaid, and absolutely a focus of that was to make sure folks could get dental care, but it was truly to make sure that people could be as healthy as they possibly could be. And that means they needed to be able to access all of the services. So we work a lot on that implementation side to make sure that happens. In 2020, in the dark days of COVID, we began convening what we call the Future of Public Oral Health Task Force. That was a group you can see kind of grayed out. We had organizational membership from across the Commonwealth came together to imagine a public oral health system that was working for everybody in the Commonwealth. We knew that we needed to harness some of the good things that were happening in those darkest days. Telehealth was suddenly easy, I'll use in air quotes, to access and much more accessible and reimbursable than it had ever been before. We were having a national conversation about racism as a public health issue in a way that we've never felt comfortable having before. So the task force wanted to take those things that were working and also understand the things that weren't working and imagine just a better oral health system for the Commonwealth. And worked to create recommendations in technology, data, integration, and workforce, why we're here today. I'm happy to say that that group was able to continue its work and to convene every 6 weeks for about 2.5 years because we were funded pretty generously through ARPA funding from a Maternal and Child Health Block Grant, from the Richmond Memorial Health Foundation, from Delta Dental Virginia's Foundation. We had a lot of support early on, understanding that system change was important. And so while direct care is important, we also really needed to think about how we could reimagine and really fix the root cause of the problems. And over that task force kept saying, it all comes back to workforce. It doesn't matter what we fix if we don't have folks to be able to provide the care to the people who need it. This was also happening at a time that there was really a tremendous amount of activity with healthcare workforce across the state. It was COVID. We were talking about public health. We were talking about the healthcare workforce in a way we never had been before. But guess what was missing from almost every single one of those conversations? It's a question. Someone answer it. Oral health. Thank you, guys. Yeah, oral health is very often left out of this conversation. And I think in some ways for good reason. I think, Gulf is a great example of employers coming together and talking about their biggest needs in hiring. Well, when you have a group of hospitals and MCOs and other really large healthcare practices talking about what their needs are, dental typically isn't going to be part of that conversation. Not because their patients don't need oral health, but because those aren't hired by hospital systems and those other big entities. They have a pretty different enterprise model and much more smaller private practices or federally qualified health centers. So from there, the task force started to work really intentionally on workforce issues and wanted to, one, aggregate all the data that was out there related to oral health. We've got pretty good data in Virginia, but it was everywhere and nowhere. And so we wanted to put it in one place. So late last year, we published the Commonwealth of Workforce Gap Assessment. What that did was bring together all the data, as I said, and provide some recommendations and identify some of those gaps. What I think is going to surprise no one is that we have an oral health workforce crisis in the Commonwealth of Virginia. And I know you can fill in nursing, workforce crisis, and I know you can fill that in across the board, but oral health is no different. Almost every single locality in the Commonwealth of Virginia does not have enough oral health providers to meet the needs of the people in that locality, regardless of their care status. And every locality in the Commonwealth of Virginia does not have enough providers to meet individuals who are insured by Medicaid or who are uninsured. Every single locality, from Fairfax to Southwest Virginia to Danville, every single one. So the task force, in addition to looking at the assessment, looking at the existing data, identifying those gaps, also worked really thoughtfully on a framework about what the workforce and what that continuum of care, or continuum of the career highway needed to look like, with a very intentional health and racial equity lens. Understanding that we also, in addition to not having enough providers, we do not have providers that look like the people that they're treating, regardless of the area of the state. And that was something that needed to change as well. So through all that, we came up with some data-informed recommendations. The recommendations themselves, I don't think are going to be super surprising to you. And I think they're also really important because they're both macro, really wanted to think long-term and large about how we address the oral health workforce crisis, and also how we insert the oral health workforce crisis in everything that's already happening. Because there's a lot of really good activities that are happening out there, and I would venture to guess that we did an assessment of all of them, if they include payment for dental or a dental assistant or whatever, they probably don't. And not because of a nefarious reason, just because it didn't come up in the conversation when that was being put together. But I hope that it is not a surprise to anybody in this room, but a diabetic cannot treat their A1C if they've got dental disease because of the inflammation, period. A hypertensive is going to have a really hard time controlling their blood sugar if they've got inflammation in their mouth. We now have ties between oral health and Alzheimer's disease. I mean, it's almost like a terrible drinking game from college. Oral health is basically tied to everything. So we wanted a macro approach and a micro approach. We also wanted some short-term wins and some short-term programmatic stuff. Are you playing the drinking game?
How excited everybody.
It's how it is. It's terrifying.
Excuse me, I wouldn't make it to cover.
So one of the things that we did as part of these recommendations, we were very some that were developing and we needed to research, some that were programmatic that we could implement right away, some that were policy change that we felt like were relatively low-hanging fruit, and some that were going to be more plays. That we're going to need appropriations and regulatory changes, and we're going to need to be really well aligned with what the community college systems are doing, what labor is doing, what all of the other players are doing. Because oral health is equally as important as all of these other healthcare professions. So some examples of some of the early successes and things that I hope we can replicate and build upon in the years to come. The highways that you saw at the very beginning. So I mentioned that oral health was often not included in the conversations that were happening at the state level. And the Blue Ridge Partnership is a phenomenal, transformative model that I think is going to make a huge difference in the Commonwealth. And guess what wasn't included? But because it literally only took a phone call for us to say, hey, guess what? Guys missed oral health. And they're like, oh my gosh, we did miss oral health. Oral health was included, and so we have some dental assisting, some dental hygiene, and dentist highways in development right now. And a huge shout out to Paul Rabel with the Delta Dental and Virginia Foundation for really shepherding them through. We also had some policy victories this year. One of the recommendations that was included in our gap assessment was making it easier for folks to practice their trade, their dental trade in the state. And really happy to say that Virginia was the 4th state because of legislation to sign on to a dental compact, which will make it easier for out-of-state dentists and hygienists to start practicing. 7 states needed to sign on. Maine signed on 2 weeks ago, so that's going to actually officially become law of the land in July, so it's going to be easier to practice. That was a direct recommendation that came out of the task force. We also are making it easier for remote supervision hygienists, again thinking about hygienists and how they can work at the top of their license to be able to work in community-based settings through some legislative change. So, and we have some big plans for 25 and some opportunities I think to really reimagine how we are looking at loan payment, how we are looking at scholarship programs to really incentivize those to be entering the oral health workforce. We think a lot about how can community health workers participate in a staffable curriculum to be a dental hygienist, a dental assistant, move on to dental school, and I think there's infinite possibilities there. And to Bill's point about identifying additional funds to support the work, because of these recommendations, we were invited to submit a full proposal to the Appalachian Regional Commission to work in partnership with our friends in Ohio and North Carolina in the Appalachian region on our oral health workforce highway development in those areas. It's a $500,000 planning grant, which is phenomenal, sure, but what it leads to is $10 million in real funding if the planning grant is successful. So again, that's going to move the needle. And I think we've got some pretty exciting opportunities ahead of us. Thank you.
Thank you. So Kelvin Turner's going to come up here and ask questions and invite you to ask questions. But I think you can see that this is something that we can't do at Claude for everybody. We're just not big enough. We have to have a statewide effort because we're dealing with the state government at that level as well as some of the local issues. There has to be an advocacy component to it. This summer, likely we will be convening groups of people. A couple of times when we put together our papers, we've convened 125, 130 people from around the state to discuss things. My hope is to have a complete list of the regulatory barriers on both the education side and the health profession side this year. But we need to know what they are and what you're seeing, because being a recovering orthopedic surgeon, I wouldn't necessarily think of dentists and what the trouble that they're having. So we need this to be pulled together. And if regional work is going to work, we need the employers engaged, and you as foundations, as nonprofits, not only are funding, but in your capacity to call up someone and say, you need to participate in this. There is a free rider problem. If Inova trains everybody in Northern Virginia, guess where they're going to go work? Wherever, right? And it is in everyone's best interest to think of raising the level, the numbers of folks coming in, and then compete after get them there. But we've got to get that cooperation between the employers and the academy. If you went to the workforce session earlier today, you heard the same thing about virtually every single workforce ecosystem. So, Calvin, here you are.
Thank you, sir. Hello, good afternoon, everyone. My name is Kelvin Turner. I'm the program officer at OBC Healthcare Foundation, so I'm excited to be up here with all these distinguished people. So we're transitioning a little bit to a fireside chat. This is going to be an engaging conversation without a fire.
Tell me about our college experience.
College was fun, but I have a couple questions for the panel, but we're also going to invite you all to ask questions as well, so feel free to just raise your hand at any moment, and I'll call on you, and we'll make sure that we address your question. All right. First question I have is, given your all's diverse background, this question is for everyone, and the various ways that you're addressing or impacting healthcare, could you tell us, where do you see philanthropy making the most significant impact in the healthcare workforce development? And we'll start.
I love this.
We have to turn it on.
I think you did. Yeah, we're all set. So I think philanthropy has the opportunity to play a tremendous role here. And I think, every example on this panel, somebody was holding the center on making that initiative happen. And that doesn't happen without resources. Paying staff time, paying administrative costs, that system change takes work, and it takes actually sitting at your desk and pushing paper around. And often that's not as sexy to fund, but it is really, really important. So I would say definitely funding collective impact models and funding time and space to solve all the problems is important. Multi-year funding is also really helpful. Those initiatives take time, and system change work is not quick. And if you're constantly having to reinvent your grant application, it's going to be a lot more difficult to get that done. I would love this. I would also think that you all should fund advocacy work. I think, all of us also talked about policy change and the importance of policy change as part of true system change. And getting that work done takes time and takes an entity to be championing that effort. And I know that I feel like there's a growing comfort with funding advocacy initiatives, but I would just kind of put an exclamation on that about how important that can be. And I also would suggest you guys use your social capital. I know that many of you are in situations where you can't lobby and advocate, but you can certainly meet with your legislators and tell them about the number one things you get funding requests for, or the things that you can't philanthropy your way out of because there are many. Or you can take the opportunity to convene community meetings to talk about issues and really use your social capital. That way you guys are trusted members of the community and you have an amazingly unique perspective on not only the problems that your communities are facing, but also the really innovative ways that they're being solved. And so I just think use your bully pulpit.
Ditto. For us, from the employer side, I don't know if you guys have heard, but healthcare is not exactly the cash cow it was maybe 20 years ago. So when I think about what philanthropy can do, it's really about sort of that seed funding, that startup funding for programs such as this academy, for what you're building, those sorts of things. Give us a few years. Let us try to get these programs in place. Help us to employ those aspects that really provide services that are not paid for. Bill mentioned everything that's paid for from the government. There are so many aspects of what we're trying to build that are not paid for. If you help us to try to build and try to start those programs, sustainability is something that from the employer side we can do. It's just we need help getting it going, getting that wheel turning. And I think that's a huge part of philanthropy. That's a huge part of what Bloomberg is doing. This is a secret. This is something that's going to get this thing moving, and then it's going to be sustainable long term.
Well, I would say something to roll with.
Sure.
I would just add in there that from the philanthropy, where they can help is aiding programs that in rural communities that oftentimes rural communities don't have voice in the government sectors. And so when we're trying to think about how to reinvest into those areas, that's where a lot of help can come from philanthropy, because they don't have advocacy space at the government level to get that focus. And so as we think about that, from a rural strategy standpoint, if we can get people connected to jobs so that they're not leaving those areas and we can get those stabilized, that we can add to our tax base by getting them off Medicaid because they're into jobs, and as a way to be able to help bridge that back into rural communities. Because manufacturing, the big manufacturing centers are going to have a hard time. There's a reason why those jobs left. And so if we can connect them to jobs that are stable, high need, livable ways, and we can use that to sustain our rural communities.
Yeah, I think maybe reemphasize some of the points that Sarah made, particularly around kind of convening the conversation and contributing to that. I think one of the things about the regional partnership concept that the Blue Ridge model has, and then I think as we see these kind of gain steam across the Commonwealth, that would be really helpful is, it helps to produce kind of that, the voice around policy changes that are needed, coming up in a true, really collaborative fashion, which I think can be really helpful, especially given the complexity of all of these things. So I would say that for sure, and also just, contributing to the conversation around outcomes that you're asking for, and longer term what those are going to contribute to. I think across workforce development efforts across the Commonwealth, I think we're really focused on recognizing the complexity of data and metrics from specific programs, of all of our programs collectively, of recognizing the differences between programs, but trying to say, we are still driving towards the same common outcomes around family sustainable wages, meaningful work, long-term job opportunities, economic vitality, and kind of contributing to the conversation on data, outcomes tracking, measurement, and making that clear at the outset of new programs, I think is something else that we emphasize.
You hear the common theme of regional collaborations. It's really key. In Virginia particularly, every region is very, very different, and the ability and opportunity to be intentional with the resources that exist there and to maximize those for the greater good of that region is so significant. The other thing comes back to those early education efforts, and it's not just health science training, but it's literacy, it's a whole bunch of other things. An educated population can then rise up to meet the needs of the workforce and to take those on and off ramps off the pathway. To Dr. Hazel's point, if you don't have access to the more challenging higher level coursework as you are coming up out of elementary, yes, it starts in elementary, and then middle and high school, you can't even be competitive to continue in further education and higher education if you don't have access to that coursework. So, funding things that are providing the educational resources as well as the collaborative community resources, it's just a common thing and can't emphasize it enough.
Shirley should speak after me so she can tell you what I meant to say. So I read someplace that the definition of collaboration is an unnatural act performed by unwilling parties. And my experience as secretary and so forth suggests that's not entirely true. The real problem is people don't have time. Nobody in any organization, for the most part, has the day job of pulling all of these pieces together and finding out about the unknowns. What is it they talk about? You've got your known unknowns and you've got your unknown unknowns. And it's finding those and putting it together. The one that we're dealing with this summer with the Secretary of Labor and Nicole is, how does the workforce development system work in Virginia? And how can that be used to bring people in, whether it's TANF funding for people who need new jobs, or any of these other programs? How, in the workforce development, people don't know about us. How do counselors in school, everybody says, well, the counselors in school have that job. You're in the banking industry, do they understand what you do? Imagine that they have to understand what you do and what we do, and then have all these jobs available for the kids. The system is not working. The education and training system is not meeting the needs of the students or the industry today. And so we have to think collaboratively about that at the macro level. At the micro level, the wraparound. The community college will tell you if they can get the kid into the second year of training as an X-ray tech, they've already got a job before they left. That'll get paid for. But as soon as the mother gets sick or the baby has a problem, they can't make it. They lose the transportation. Those types of things, the student success funds, at the community colleges and others are important. It's the wraparound stuff. Another thing is building capacity. In the government sector, you hear a lot, we'll offer scholarships and we'll lower the tuition costs, but a public entity can't raise capital easily to build the capacity. So we need to think about how we help support building capacity and think about that regionally. An ambulance trainer for an EMT costs about $150,000. Can we put one in every school system and then have it sit 98% of the time? I don't know, any of y'all want to pay for that? So likewise, all-in-one anatomy tables to teach anatomy is even used in medical schools now. $103,000, $105,000 plus maintenance. Can we put that every place? So how do we organize ourselves so it makes sense? And then transportation. How do you get the kids I shouldn't say kids, how do you get the people to it? So these are things that have to be thought out regionally based on resource availability. When you got 1.5 million people like in Fairfax, it's a different problem. You got 10,000 in Rockbridge. So anyway, those are things that we need to be convenient about.
Thank you. Staying on the world of philanthropy, we may have some funders in the room that don't explicitly fund this type of work. What is their role? How can they aid or support fellow foundations or partners in this effort? Anyone can answer that.
Lead follower, get out of the way, somebody said earlier today. You may not be in healthcare, but these same lessons apply to other industries. The whole issue of scholarship, student support may not be healthcare, but we need that. Understanding that it is out there and supporting where you can makes sense. Shirley, you've got some good ideas?
Use your networks. Use your networks. I sat at lunch with a gentleman who's with the Richmond Community Foundation, specifically working in the northern neck of Virginia. And I said, hey, I need to know what you're up to because the work that we're doing with Rappahannock Community College, and they're building a brand new health sciences center for education that's going to benefit our 14 little small school systems in that region. And I said, I need to know what you're doing because I have a thought. What are you doing with them? And he's like, well, really nothing right now. So we're going to have a weekly call. Network. Because you can facilitate and help with some of that change. Today, Kelvin was with us at lunch and we're all doing different. I said, that's what we do. We connect the dots. It's like, oh, yes, and it's that advocacy and networking that is so critical and that brings it all together.
Well, I'll throw it in. Great. Just to build on that point, something I was going to mention earlier, because I think Dr. Hazel used the term ecosystem, and it's interesting because I've noticed us use that term more and more as it pertains to workforce and many things. But one of the things that I always try to think about in relation to that is really an ecosystem at the core. It's a living thing, which means it's always changing, which is one of the things that's most challenging. And I think it's actually a really interesting point, to think back to a lot of the conversations that we've had really kind of as a group, and the question you just asked and your point about collaboration is, the ways in which we are trying to build networks and always come back to how we collaborate and coordinate with one another is partly a challenge because our networks are always changing, and the way that we're trying to approach problems is changing a lot too. And It might seem like an overly simplistic thing to say, but I think it's a really important one just because solving these challenges, I think, is going to get more and more complex because of the pace of change that we're all kind of, encountering. And I think it means that those networks are more and more important, and it's helpful that you all are able to be part of that in whatever form that might be.
I think I would harken back to that slide that I showed you of what the Ballot Academy will be at full capacity. And if you think about the industries that we have, no matter what that industry is, it is more than just monolithic. It is more than just doctors or nurses or whatever. All of these organizations today, whether you are an industry or healthcare or anything really, depend upon a wide swath of available talent and healthy talent. And as soon as we can get to the point where we understand that we have to work together, that we can't keep parsing things out to smaller and smaller and smaller degrees, the better off we're going to be. It is a community. It is an ecosystem. It is something where we have to work together in order to make sure that it will actually work long term. So.
I really don't have much to add other than you probably are working in this space. It might just be in a very, a scalpel version of the space, and maybe you're funding transportation or you're funding research that is contributing to something that might be more macro what we're talking about. So I think that I love the ecosystem example, and I think share, talk, communicate. If you get a funding request for something that isn't aligned but seems smart, tell them where else to send it, or send it yourself.
Thank you. Next, I wanted to talk about employer engagement. We talked about how important it is, how crucial it is to be able to attract and retain employees in this area. What are we seeing, and what are people doing in this area of employee engagement?
Geez, that seems like a question for me.
Names at the top.
So I think what I'd say is that employers have come to realize, probably more substantially over the last 10 or 15 years, that we can't be passive in this process. We have to be actively engaged with our educational partners, our community partners, et cetera, to make sure that we have a capable workforce. I think also the flip side of that coin is that our academic partners particularly, but also government and also philanthropy, we've come to a situation where the traditional models, the traditional way of thinking, the traditional way of educating, they just are not keeping pace. There's sort of a funny but not so funny thing in medical school, where in medical school for 4 years, it is a known saying that 50% of what you learn is going to be obsolete by the time you graduate. The problem is you just don't know which 50%. And what I would say is that the pace of change within healthcare, within business, within anything you can probably imagine, is happening so fast that our academic programs can't keep pace with it, our governmental organizations can't keep pace with it, I'm sure you guys can't keep pace with it. And so we have got to work together, and we have got to be able to have open and honest and candid conversations about, if we've done something for the last 30 years, that's great, but is it still applicable? Is it still something that's going to serve the needs, going to create the workforce, that we need moving forward? So.
Totally agree, and would also take it down a notch or a level as well. And that one of the things that we do that is very specific to dental, but I imagine not specific to dental, is the ecosystem or the hierarchy of oral health workforce in a practice. You have the dentist, you have the hygienist, you have the dental assistant, and one of the things that we're looking at with the highways is the importance of having a certified dental assistant, because you need to be certified to be able to go on and be a dental assistant too. However, in Virginia, you don't need to be certified to be a dental assistant. And the dentist and the dental hygienist don't necessarily value that certification. And there is an opportunity, I think, for us to help folks that might be at the higher end of that hierarchy understand the value in lifting up and helping those that work for them and with them through that continuum. And I think right now, that isn't always seen, and so the folks that might be your next hygienist or your next nurse or your next physician don't necessarily see that path because the people who are in front of them aren't making it readily available and they don't value it. And so I do think that that's a component of it as well.
One of the big employers that we have to think about is school systems. And I can tell you one of the programs that gets funding through the Blue Ridge Partnership is an oral hygiene program at EC Glass in Lynchburg. And they had a wonderful teacher who trained in that program when she was in school. And the program had become somewhat more elective. She has come back. That was her highest educational achievement, was graduating from high school. She's not eligible to teach beyond a certain period of time, because so she needs to now have further education. So you may not be in healthcare, but you may be in if it's an employer or a funder of education. Let's elevate that woman's career trajectory by helping her get that training. Those are things that are out there that tie in that we just don't think about unless we get out there, but we need these folks. Another area that I spend a lot of time thinking about, and the team's heard me say this, is let's say we have a nurse. She's come through, she's a great nurse. Now she's 36 years old and she comes into a room and somebody big and fat like me is lying in the bed. She says, my back is not going to move this patient anymore. What do we do with her? They always say you ruin a good nurse by giving her a clipboard, but she can teach. She can go to administration. She can do different types of nursing, but it may require different training. So that highway has to go out as we think about the future for people. You know, when you were hearing today, and sometimes you have people living to 80, and if we really hear Social Security is going to go broke, we're going to be working longer. Is it really reasonable to expect that we can front-load our education system and be done with it? The answer is no.
Yeah, that makes me think about, how do we balance addressing those immediate needs versus those long-term sustainable initiatives. Question? It's okay. It's fine. The next question I have is for Nicole. Unless we have any from the audience. I haven't seen any. Yes. All right. Yes, please.
I just have a quick question. I'm pretty loud. I don't think you need that. For Dr. Maisel, I think you said something about math being something that prevents a lot of people from moving further, especially in nursing.
And in advanced manufacturing, and in almost everything. I think even our banking friends like people who can add.
So what is the plan for addressing that, and how far back do you need to go?
I think from what we have been dealing with, and Shirley is better at this than I am, but the issue that for us is if you haven't had the course early enough, you can't take the next course in the sequence, and you can't support the science and energy. So it's really making people aware that this math stuff is not a joke. It's important. Only you can do it, even if you are broke. These are things that are really important that kids understand early on. Shirley, have I said that more or less right?
Absolutely, absolutely. In every school division, we were just at a particular Southwest Virginia school division, and $16 million cuts don't help bring along the academics and the teachers who are going to do that work to the level of quality that you want that for kids to get the skill sets that they need to build for being competitive.
And I think another place, so that's really, we've been focused more on the awareness of the need to take the course, but as my breakfast conversation this morning, did you want to address that? Go ahead. Please.
Sorry. So I am a retired superintendent, former CTE director from Henry County, on North Carolina and Middle State. And we had a robust CTE program, wonderful program. putting kids forward, had already heard a way forward, and now we had to turn to a CA. We're also on our teachers. And it starts in kindergarten. I mean, I love my preschool, that's where you're, running school. But in kindergarten, you have, y'all look at the DOE website where it talks about all the teachers that are teaching out of their assigned area. And some people don't have that problem in some areas, but in our area, like you said, when Northern Virginia's training them, they're staying in Northern Virginia. And if we need these medical people and dental, because what child can be confident and apply for jobs and use their education when they have, poor dental health? But anyway, I know I'm not a key speaker, but we need the education and we need stronger teachers, and that is the key to every ecosystem, and we've got to figure out how to get every people.
Having the teacher who can teach math is part of it, and we spend a lot of time in the public sector thinking back when I was there about literacy and third grade reading levels. I would submit to you that literacy and numeracy have to happen, and they have to happen in early childhood to really make that work. And so, again, we get focused, we can't do it all, so I don't have a good answer for you, but I know where I would go.
And from the employer perspective, what I would say is, yes, you have to start as early as possible, and as that child develops and grows, help to create a curriculum that shows the child why it's important to know that.
Yeah.
Not just that it's, I just now got to take training. I don't
Yeah.
care about training,
Yeah.
but help to create those programs that are problem-based, that are industry-based, that actually teach the child something, as opposed to just passing the test.
So,
I'm sure the last thing y'all want to hear from our healthcare workforce is going back, but I wanted to share two comments and I'll pose my question if you could, because I think this is the relevant comments. One is associated with the work we're doing at Virginia and Region 9. We've taken a look at how to retain the students within the school systems that we have in our region. We've got some of the best colleges and community colleges in the country, in the Commonwealth of Virginia. Because of that, we import, and this is compiled with the South while we're sitting here, a total for all Virginia schools, 28% of all students enrolled in Virginia colleges are from out of state. We're tracking UVA, which is one of the colleges in Region 9, we focus on was 34.5% of all students at UVA are from out of state. So we're focusing at Virginia, how do we keep them in the state, as well as I call Virginia brand and own, how do we keep the Virginia brand and own in the state? Because of the fact, I take a look at my nephew's former fiance because of what she did. She was in nursing school at Bradford. She had 18 job offers her junior year. One of them was at the Virginia hospital system. 17 were from out of state. She now lives in North Carolina. Because of the fact that's where she was being recruited as a college.
What did you do?
So I guess the question is, what we're not seeing is that employer collaboration like we talked about at the level that it needs to be. Because kids coming through secondary schools, elementary schools, community colleges are not seeing that path to where they can have a job. So they're looking elsewhere. And we in Virginia are not doing a good job. So how do we improve that collaboration into the elementary schools, public school systems, private school systems, community colleges, into universities? Because I can take my oldest daughter graduated from Virginia Tech. She moved to Maryland because she had people from Maryland.
It's not you.
But that's what we're seeing. And I remember first trying to go into healthcare, and for her to go to graduate school for her healthcare degree, she's got to go out of state. Where do you think she's going to end up? Out of state.
So a couple of thoughts. Number one, yes, we have very high quality higher ed in Virginia. I can also tell you that the community college system, which is dealing with most of the people that need certificates and other things, is funded near not only is funded at a very low level. I can't remember the exact numbers compared to most every state. Our funding for community colleges is pretty minimal. And Texas beats the hell out of us with that. And I wish I could give you the numbers, but I can't. I would encourage you to ask somebody. I can tell you that the folks who go to the community colleges tend to stay locally at a much higher rate. And I've heard those numbers. I don't know what it is for university, but I think that's like 30-some% stay in state. Community colleges for 75 or 80%. It may be the nature of the student who is more wedded to the region. The reason they're community colleges is because they aren't as mobile. So, but one of the things about health jobs, health professions, and health sciences is that they're everywhere. And if they can be taught locally, I think you have a really high chance of helping somebody stay in an area where they are and get a job. And if they have to move, those skills are often transferable. Probably more importantly is giving experiential learning when you go. I think that if an employer has the opportunity to take a student in and do an internship in a hospital that may not be able to be patient care, but you get in a system and you meet some people and you learn the culture a little bit, hopefully they'll want to stay with you. If they don't, change you. But I think that it's really what you hear folks saying, and Nicole can comment on this more, but even the governor's program would like every student coming out of high school to have a workforce certificate or a ticket to higher education, one or the other. And that requires employers to make available work experience. And so those are things that I would put off the top.
We didn't mention it in there, but one of the things that Power is doing is they moved their hiring age from 18 down to 16, so that students can start in their junior year to do a non-certificated role, be able to experience the healthcare system. And so, being able to your point, and I think that's true. Eastman Chemical Company is in our region, and they're starting to let do work-based learning, apprenticeship kind of roles starting at 16 as well. So being able for students to be able to get into the setting, going back to somebody said, to answer the question, why do I need to know this, how is this really going to work, is being able to, it is opening your door, letting them come in, and we had that conversation of understanding also that when they come in, they aren't skilled at this level. We're growing our workforce, so they're going to make errors. They're going to. It's also learning how to handle.
Not in the hospital, they're not.
But how you open the door? How you throw them up into those roles?
Did you have a question?
Well, my question is how can we get employers engaged early and often to get in front of these kids when they are at those levels, so they know here's a track, here's a path, here's a job when I'm done.
Yeah, if I can add one more point back to the health sciences highway, one of the things that I think is really noteworthy about that and will be kind of the next, I think at least ideally the next level of that is, we talk about career pathways and the fact that in order to build those in the right way, we need, from the government standpoint, from the Commonwealth standpoint, labor, education, economic development, workforce, all at the table to think about that. Ideally, we would, from a local or regional standpoint, be able to get to the level of employers being part of that conversation and being able to show specific pathways into jobs that are in high demand local areas and that kind of thing. So that it takes it from more of the kind of the abstract, more academic standpoint of you learn this, it translates into this job 10 years from now. I think the other piece that collectively we haven't, and I mean this at like even at kind of national, global level, we haven't really thought so much about is if you start in this job, given the pace of change that we talk about, what does that mean for where you could go with the job 5 or 10 years from now? How might that look different on your highway of today versus the highway of the future, and how do you prepare for that change? But I think at a very specific level, there's a role for employers to play in actually defining out career pathways and the highway, so to speak, that makes it really clear. Of those 17 employers, what types of jobs do you get? That you're looking at, like what is that? what are all the different factors and skills that you might get that may sway you towards taking one in Virginia versus somewhere else, because you really have an educated perspective on your long-term pathway and where you want to go. So. Okay.
I think we have time for one more. Those young lady in the back.
We were talking earlier about teachers and that we need teachers to be able to teach the math and the literacy. Is there, I'm not aware of a Teach for America program in Virginia. Is there a strong Teach for America contingent here? I was on the board of one in Jacksonville, Florida.
It's here, but it's not as strong as it is in some other states.
Okay.
Do you want to do the one, yeah, over here? Yeah, thanks.
Figuring out these pathways both in the medical arena and the oral arena is great. Is there anything like it for mental health?
For the who?
For mental health?
Mental health.
That has been a topic all like recently. This year, the General Assembly moved to open up some of the standards for QMHPs so that more people could get into that. I mentioned the behavioral health technician earlier. There's now the code change would allow behavioral health technician 1 and 2 with the idea that that could be experience or credit for prior experience, prior learning, and transition, so that could perhaps become a QMHP. But where we've been trying to focus is on the programs that where people can actually work while they're learning. And so, for instance, let's take counseling. If you have to get a degree and then you have to get 3,000 hours of counseling, and there's no one to be your mentor for that, or no one to pay them to be that, you're not going to get it. So can we break that down? This is a conversation that's active right now with health professions. Can we create steps so that at this level you can work and do this? Believe it or not, up until the most recent General Assembly, master's level psychologists couldn't treat in Virginia, but we can use them. So the code has been changed and the rules are being written so they can be part of care teams. But we have to enable them. Some will look at that and say, oh, you're dumbing down the profession. Well, no, we're not making the profession any dumber. What we're trying to do is create access to the right level of services. So that whole sort of ladder of thinking is something that we have been engaged in. And Shirley, you've got something for me.
I do. If you would like a copy of the hospitals, healthcare, helicopters, and more book, it's also in Spanish. Please come see me and I'd be happy to share that with you, and we can talk more about how, if you're interested in looking into that on a larger scale. But I think that you will enjoy it.
Final thoughts, anyone? All right. Well, thank you all